Good afternoon, ladies and gentlemen. My name is Quyên from Vietnam, and this is my hospital. Thank you for inviting me to have this talk. My topic is the anterior approach for total hip arthroplasty. So, right now in my country, most of surgeons, probably more than 90%, are performing hip replacement through posterior approach. Only a small group of surgeons using direct anterior one. And I assume that posterior is also the most common approach here. I'm not standing here and trying to convince you to switch from posterior to anterior. I just want to share with you all the difficulties and pitfalls I have encountered in the past and hope you can find something interesting from a young surgeon's perspective. Firstly, when we do a reviews of literatures, we can get a bunch of papers comparing direct anterior approach with other approaches, mostly the posterior. In general, the data show that in short term, DAA can bring some benefits such as shorter hospital stay, less pain, fast recoveries, lower rates of dislocations, and less length discrepancies. But it also comes with some trouble like longer operative time, more numbness times, higher risk of intra-operative fractures, and it takes more time to learn. And in long term, there is no difference in functions between DAAs and the other approach. How about data in Vietnam? This is a study conducted in Hui's medical school 2 years ago. They is comparing two groups of patients, including 55 patients with posterior approach and 47 patients with direct anterior approach. Surprisingly, they have a really high rate of malpositionings as a tabular component with direct anterior approach. So it's pretty clear that the recent evidence cannot advocate for the superiorities of the DAAs. So why we need direct anterior approach and why this approach is becoming more and more popular. Take a look at the benefits of DAAs again. It is obvious that shorter hospital stay can lower the cost, which is very important to the healthcare system nowadays. Besides, while balancing less length helps us avoid losses, legal problems with patients, and at the end of the days, we all want to sleep well. That's when we decided to leave the comfort zone and try new things. And there will be potentially new challenges. We usually consider that femoral elevation and preparation is the most difficult part of DAAs, but in reality, this approach also comes with a higher risk of acetabular component malpositions, and sometimes unexpected things like this happen. So, how can we make a safer, smoother transitions? The key is to understand the anatomy of the hip joint, the capsule, the tendon insertions in order to perform a good release. You can learn from your mentor, participate cadaverous workshop, or visit other surgeon. Unfortunately, the risk of out of the shape joints do not decrease with time. Intraoperative imaging can help surgeons place the cups in a more accurate position. We can take advantage of this, but CMs is not always available. It increases the cost and surgical time. It comes with the risk of contaminations and requires a technicians who know how to take a proper image. Preoperative digital templating is a powerful tool, helping us determine the position, the size of the component, and estimate the leg length and offsets. It only takes 5 minutes to fully plan the surgeries, but the software is obviously not cheap. Fortunately, we still have one effective and free solution, the transverse acetabular ligament, which is able to identify in more than 90% of cases, can help position the cup perfectly. Now look at the results, how I place the cup before using TALs as a navigation. Most of the time, my cups are too vertical or too much anteversions. But after using the TAL, the cup is placed in a more accurate and consistent positions, even with long conventional stem. Once we feel comfortable with the longitudinal incisions, we can try the beaconies because evidence shows that transverse incisions can help lower wound infections. As you can see in these time-lapse videos, I only use a regular operating table for a beacony direct anterior approach. But new things continue to be introduced. The superpass is being now promoted as a perfect method for hip replacements in Vietnam, not requiring capsulectomy, give patients a faster recovery, and it requires a shorter learning curve. I agree that superpass requires shorter learning curve, but DAAs not always require capsulectomy. Like in these videos, I am repairing the capsules at the end of the surgery. Besides, unlike superpass, we can easily handle trochanter fractures without extending our incisions by using anterior approach. So if the previous information is not enough to convince you to adopt a new approach, let's look at the following examples. It is obvious that minimally invasive anterior approach is not suitable for these difficult cases. We need an extending posterior or lateral approach. However, posterior incisions may not be safe in these situations. That's why we need to know to do well more than an approach. So in conclusions, each approach has its advantage and disadvantage. Only 3% of surgeons are willing to adapt anterior approach. But as soon as we know how to overcome difficulties, we can enjoy its benefits. Knowing more than one approach, helping us choose the safest and the most suitable procedures for our patients. So my choice today is bikini DAA for female patients, conventional DAA for other patients, but I'm still using posterior approach for difficult or revisions cases. Thank you for your attention.